And Channa, have you joined?
Yeah, I'm here.
Channa, right? Okay. I think we move now. It's 7:45. We move to the second case. So it is on asthma, and Abhi will present it. Abhi is a third-year registrar, but just forget about it. What the medical students should understand is, and when listening, just see whether she covers the relevant areas, how well she presents, and how well she discussed the examination, summarize it within a given time period, and how she answered the questions. And some of the questions are commonly asked questions. So I think whatever the case we give to you, those are standard cases. There's a core knowledge we expect from you. So what we ask, the most of the time, the question we ask is to test that core knowledge. And then some other questions aimed at to see whether you go to a 60+ mark, or at the end, whether you can go for a distinction marks, where we will ask a little bit tougher questions. Okay, Abhi, please start.
Good evening, sir. Today I'm going to present sorry, so my screen got stuck.
Akhil, you can help, isn't it? The slides are not moving.
Yeah, just a moment, sir.
Yeah, Abhi.
I can present, sir. That my slides are not moving. That's why, yeah. I can share it. Yeah.
Akhil, please allow Abhi to share the slides. I can see the slide, main slide, the case-based discussion of bronchial asthma. Can you move the slide, please? Okay, Abhi, while trying to sort this out, continue to present, yes.
Yeah, sure. This is Master A, who is a 3-year and 2-month-old third product of non-consanguineous healthy parents from Vattala, presented with a complaint of fever and of a day duration and cough of 3 days duration, which is worse since the evening of the day of admission. History was taken from the mother, who is studied up to O levels and currently being as a housewife. Sabari was a healthy child since birth, where he had infrequent cough and wheezing episodes occurred from the last March after a COVID illness, which needed of an extensive management at LRH. This current episode, preceded by fever, which was preceded by cough of 3 days duration, triggered by dusty environment due to house repair works, cough was moist, diurnal variation has been noted, worsened with time associated with shortness of breath, more on nights, wheezing for last 2 days duration, and on the day of admission, symptoms worsened a lot with a spike of fever, which was moderate to high spike, which responded well to the paracetamol and did not have any chills or rigors. Initial day, that was the day 1, he was seen by a GP and given with chlorpheniramine, azithromycin and salbutamol of 2 days duration. From the second day of illness, because of the worsening of cough throughout the day, and he started producing mild amount of sputum. Cough was disturbing his activities and sleep, which associated with chest pain, post-acid vomiting, and reduced intake. With the worsening of symptoms like noisy breathing, wheezing, positional disturbances, the child could not talk or breathe as usual properly. The mother admitted the child to the LRH. On admission, child was restless, could not complete a sentence, and was on distress with severe cough and wheeze. At the PCU, nebulization was done nearly for 60 minutes and transferred to the ward, where the special medications were given to the child during the initial few hours at the ward, according to mother. Blood investigations were taken with a chest X-ray, which was told to be having significant changes, and also started on IV antibiotic. Hold on a second. He was on oxygen throughout the stay and still on, while only the frequency of nebulization was reduced. By the next day morning, he improved a lot in general well-being, including the symptoms. Regarding the previous episodes, he is a known child with frequent wheezing since early this year, after an admission with a lower respiratory infection following COVID-19 infection. He was perfectly normal except upper respiratory tract symptoms once in 2 months, which needed oral medications from GP level medications. No previous nebulization history is noted. Since the COVID-19 infection, he had to stay 2 weeks in hospital, but he was not oxygen dependent, but significantly had cough and shortness of breath with fever more than 3 days duration, and had some red eyes, red mouth and few rashes. Given special medications on the day 4, possibly IVIG, and some injection due to the blood abnormalities, which was a subcut injections. Since that admission, mother noticed few trigger factors for his cough and SOB, like cold food, air, dust, laughing, excessive crying, always induced cough with diurnal variation, ends up with always consultation at the GP level. Up to now, thrice she nebulized the child, none of them needed hospital admissions. Monthly twice, the child was on salbutamol and chlorpheniramine and sort of an antibiotic. Activities are disturbed, including play, schooling and sleep. He was started on preschool also 4 months back. Due to the illness episode, that schooling activity also disturbed. All had symptomatic relief with the consultations. No cough while feeding suggestive of GORD, no chronic cough contacts at home, no recent visit to TB contacts, no exercise intolerance, edema or dyspnea suggestive of cardiac failure, no epigastric burning sensation, regurgitation, burps, vomiting, no odorous nasal discharges suggestive of foreign body inhalations, no recurrent chest infections, no poor weight gain or recurrent abscesses and recurrent hospital admission suggestive of any immunodeficiency. But since childhood, he has an atopy history where he gets severe papular urticaria with even small mosquito bites. During my systemic analysis, his urine output was normal, no urinary symptoms, bowel opening was normal, no abdominal pain or altered bowel habits, and no seizures, headache, and restricted neck movement suggestive of meningitis, no rashes or joint pain or swelling. Regarding the past surgical history, no surgeries like tough repairs in the past. Other history components, he does not have any allergies for food, drugs or plasters, but there is a family history of bronchial asthma to the paternal grandmother who was on inhalers for nearly 15 years and she passed away 1 year back. No history of TB or chronic illness for that grandmother. Father had childhood bronchial asthma and the mother has a food allergy where none of them had eczema or atopy. Immunization wise, he was given all the vaccination, given the 3rd year vaccine 2 months back. Development wise, he has all the milestones, he achieved all the milestones age appropriate. Regarding the birth history, mother is an elderly primey. She was 41 years while she was delivering him. She had 2 miscarriages. Both of them were first trimester miscarriages. Antenatal period was uncomplicated. It was a planned pregnancy with folic acid and proper supplementations and proper follow-up. Ultrasound scans were normal. He was delivered by an elective section with the indication of elderly primey. No PBU admissions and postnatal period was also uneventful. He was exclusively breastfed up to 6 months, followed by weaning. no recurrent chest infection, no delayed cord fall or bleeding manifestations, no abscess formation or diarrheal illnesses during the infant period. Regarding the diet history, although he took 3 meals, according to the dietary pattern, there were only 2 main meals with 3 snacks where I could find out a calorie deficit. Regarding the social history, my mother is a 43-year-old housewife, where the father is a 45-year-old accountant, and the father is a stepfather. This is his second marriage. From the previous marriage, he is having a 5-year-old girl who is also living with the parents. And totally, there are 5 people living at the house. They are having an own house at Vattala, 3-floored house, where in the ground floor they are residing. Currently, there is a repairing work. The house is beside the road, and now there is a pet exposure where they have 2 cats and lovebirds. No passive smoking. They infrequently uses mosquito coils, and nowadays the usage is a bit high. A gas cooker is being used for the cooking. Weekly, mother washes the bed linens and curtains. She mops the house once in a month. Nearest hospital is 15 minutes away from their home. They are having a motorbike to travel if there is an emergency. So regarding the mother's concern, mother attribute this to the illness the child had a year back, that is the COVID-19 illness. She worries whether the child will end up in inhalers for a long-term period. She expects to be given a clear diagnosis and a management plan to be followed up at LRH. Few myths about the inhaler usage and nebulization with the mother is still persist. On my examination, growth parameters were normal. Weight is 13 kilos, which is median to -1. Height is 150 with -1 to median to -1. Weight over height also -1 to -2 SD. Child looks ill, agitated, febrile, tachypneic and dyspneic, not cyanosed, not pale, no ankle edema, no clubbing, no generalized lymphadenopathy. I could see a dry skin with healed papular urticarial rashes, signs of atopy. Cardiovascular-wise, pulse rate was 120 with good volume, and peripheries were warm with a CRFT of 2 seconds. No murmur, blood pressure was normal with good pulse pressure. On respiratory system examination, no chest wall deformities, no scars. Move symmetrically with respiration. Trachea was in center, symmetrically expanding lung fields. With tactile vocal femmeters was resonance and resonance on percussion. Respiratory rate was 52 breaths per cycle, and there were subcostal recessions, intercostal recessions, supraclavicular recession, and also nasal flaring. On auscultation, air entry was equal with vesicular breathing all 6 zones, with bilateral, full-blown polyphonic rhonchi and crepitations. Abdomen was soft, and there was 2 centimeter hepatomegaly with the upper margin at the 7th intercostal space, possibly a push-down liver, and there were no other cardiac failure features. CNS examination was normal. According to these history and examination findings, my summary is 3-year and 2-month-old boy, Master A, who is the only child following 2 miscarriages of a non-consanguineous healthy parent, presented with the features of acute infective severe attack of bronchial asthma. He is an infrequent wheezer since 2 years and 9 months of age, following a possible mild MIS-C infection, who developed once a month episode since then, total 3 nebulization up to this 9 months of duration. Current episode was precipitated by a dust exposure, where he had several risk factors such as positive family history for bronchial asthma as well as for allergy, and still persisting triggering factors for the exacerbation. Except an atopy, personal atopy history, other history evaluation points were normal. Examination showed an ill-looking child in distress with the SpO2 of 88% with bilateral rhonchi and crepitation with the tachypneic and dyspnea and a push-down liver, suggestive of acute severe infective attack of a bronchial asthma. So my problem lists are acute problems, acute severe attack of a bronchial asthma, possibly with then secondary bacterial infection, and oxygen dependency even at the day 4 where I took the history. Chronic problems are improperly managed wheezing episodes for last 9 months and persistence of trigger factors, poor knowledge and myths about the illness of the mother. With this problem list, I have made a differential diagnosis, possibly acute severe infective attack of bronchial asthma, or episodic severe viral induced wheeze with secondary bacterial infection, or bronchopneumonia with severe wheezing episode. Yes, sir.
Thank you, Abhi. You have come to the end of your history taking and presentation of the examination also. And you have summarized it and gave the differential diagnosis. Chandra, would you like to ask some questions?
Yeah. Okay, Abhi. Yeah. So first, we have taken a very good history with details of the current situations as well as examination and going into the details. Okay. So seems to be this child presented with an acute attack. What is the severity of this attack?
So this was an acute severe infective attack, sir.
Okay. So, yeah, how do you assess the severity of asthma attack in a child presenting with increased symptoms?
Yes, sir. We have mainly 4 attacks we can classify in the bronchial asthma, where according to the SpO2 level on admission as well as the hemodynamical stability, plus respiratory rate and cyanosis, child's conscious level, use of accessory muscle and auscultation, we decide on the severity. In this, according to this child was agitated on admission and he could not complete a sentence, where the SpO2 was less than 92% and respiratory rate was very high and tachycardia. So I categorized him under the acute severe attacks.
Okay, so what are the clinical criteria you are using to assess the severity of an attack when you assess? So when you encounter this type of child in a say less sophisticated environment or a place where you don't have the much facilities to monitor the child with equipments?
Yes, so I would be asking, I would be looking at the child whether the child is drowsy or agitated. And also regarding the clinical parameters, I would be assessing the tachypnea, pulse rate, and use of accessory muscles with the resuscitation.
Yeah. Okay. Any other practical things you can use? Okay, we'll count it. Yeah. So then, one of the important thing during this acute episode to identify is life-threatening episodes, life-threatening attacks. Yes. What are the clinical features and the other features with other available equipments, investigations to identify a acute life-threatening episode?
Yes, in the acute life-threatening episode, the child would be drowsy, first of all, and child would be poorly responding, where he won't be agitated, and we can notice a cyanosis. And all the other episodes, the child would be having tachycardia, where here we will be noticing the bradycardia, and child would be having a reduced respiratory rate, maybe due to the depression, if the child is having life-threatening attack. And also chest wall recession would be very much less due to the poor efforts. And regarding the we will be having the polyphonic rhonchi and the crepitations in acute severe attacks, where we will be having a silent chest in the life-threatening one.
Yeah, so the child's general status. Okay, so when they develop acute episodes, they are fighting to get oxygen into the system to relieve the hypoxia. So they use these accessory muscles. But finally, when they get exhausted or this life-threatening stages, yes, their effort would be less, drowsy, will respond into your management, yes, and finally develop cyanosis. And the effort is obviously, so the fighting would be little less at the end, and obviously silent chest. That is one of the important things to differentiate from the clinical improvement with the life-threatening asthma. Okay, fine. And during your presentation, you said child has been nebulized for 60 minutes before transfer into the ward. What did you mean by that? Nebulization for 60 minutes?
Yeah, so they have given the back-to-back nebulization. So,
what's the meaning of back-to-back nebulization? How do you do that?
They give 20 minutes 3 times with ipratropium and salbutamol with driving it via the oxygen with normal saline for 20 minutes up to 3 times, 20 minutes each, total 60 minutes.
Okay, so if a child presented with evidence of acute severe asthma, if doesn't respond to with your back-to-back nebulizations, how do you proceed? What are the other available options?
Yes. So while I'm giving the back-to-back nebulization, with the back-to-back nebulization, I will be assessing the child back to assess the improvement, clinical improvement and the general well-being. If that shows persistence of acute severe attack, I would be considering the second-line drugs. My first option would be max sulfate, IV magnesium sulfate, 40 milligram per kg over 20 minutes. I would be giving. Ideally, the second dose would be given at the PICU.
Okay, other options?
During the infusion also, sir, I would be continuing the nebulization. I can't stop the nebulization, and I would be ensuring that the child is getting adequate hydration, and I would be ensuring the saturation is maintaining, and I will consider the second line drugs like aminophylline and IV salbutamol. If the child is not on theophylline, I would be considering aminophylline bolus followed by infusion. And if salbutamol is available, I can start IV salbutamol infusion after the second dose of max sulfate. And
okay, okay, go on.
And also I would be considering a chest X-ray as well as arterial blood gas if there is a poor response to exclude complications.
Yeah, what's the place of chest X-ray in a child present with acute attack of asthma?
Yes, if there is a poor response, I should be considering a pneumothorax, sir, in an acute severe asthma. That's why I'm doing a chest X-ray.
Is that only pneumothorax? Yeah.
In emphysema, sir, I should subcutaneous emphysema and collapse consolidation.
So what are the other possible differential diagnoses when a child presents with increased respiratory symptoms or breathing difficulties?
The secondary bacterial infections, sir, first one.
Okay, don't be always secondary. Yes, child might present with pneumonia itself. It may be even viral. No, bacterial pneumonia also, yes. Sometimes at the initial stage might be difficult to differentiate, or even child might have pneumonia and bronchospasms as well. So these types of situations, complicated situations, if the child does not respond to our usual management, then, or especially if there is a physical signs, as you also mentioned, bilateral symmetrical signs usually, but the signs are asymmetrical, or breath sounds are less in one side, or your physical examination reveals some abnormalities like crackles, crepitations, bronchial breathing. Yes, you have to do the chest X-ray to assess of the possible other differential diagnosis as well as the pneumothorax. But pneumothorax or special tension pneumothorax is obviously a clinical diagnosis. You should diagnose it clinically and act fast before seeking a X-ray facility. Yeah. Okay. So once you child admit to the ward, how do you manage this child? How do you gradually wean this child from oxygen as well as respiratory support and nebulization?
Sorry, I could not hear you. How I wean off? Am I right? Yeah.
Yeah. So once the acute stage is over, or that when you manage the acute stage during most day, then how do you gradually wean this acute nebulization which required acute stage, and how do you gradually plan to discharge this child?
Okay, sir. Once the acute condition settled, if the child is on aminophylline, I would be reducing the strength of the aminophylline gradually. And nebulization, I would have put the child on 2-hourly or hourly salbutamol nebulization with salbutamol plus ipratropium 4-hourly. I would be weaning off from 4 hour to 6 hour, 8 hour. And then SOS, while I am weaning off, I am getting back the child to the inhalers for the oral salbutamol for the moment. And also I will make sure the child is out of infective part. If I'm continuing the IV antibiotics or oral antibiotics, I would be continuing that for a significant period as he needs. And I will make sure the child, as this child is an infrequent wheezer, and one of my problem is improperly managed previous wheezing episode, I will be considering starting inhalers for the boy, and proper knowledge to the mother regarding the inhalers, as she is having some concerns about the long-term inhalers usage.
Yeah, okay. So, how do you decide about this? What is the place of inhalers? Why do you use inhalers? Why it is important?
Inhalers, rather than the oral medications, inhalers are preferred because their action is fast, as well as while we are giving that, they will achieve. We can achieve the control immediately rather than the oral medications. That's why we are giving.
So inhale medications. Inhale is just a method of administering drug into the body. But what are the drugs that you want to continue as long-term medications?
For him, sir, I can consider long-acting bronchodilators, as well as plus ICS as reliever and prophylaxis. Or I would be considering beclomethasone plus salbutamol as needed.
Okay, so what is the most important drug in the long-term management of asthma?
Steroids, inhaled steroids.
Why it's become most important drug?
Because that comes to preventers. It's not the reliever; it becomes preventer.
Yeah, because asthma is a chronic inflammatory condition, so we have to use anti-inflammatory medications. So the currently available best anti-inflammatory medication is steroids. So as you mentioned, when we cannot use oral or systemic steroids for longer durations because of its obvious side effects, so because of that, we use this inhaler route. The importance of inhaler route is we are just directly giving the medications into the site of problem, where the problem is with the breathing tubes. So we are just giving the drugs directly into the airway, so directly to the site of action. Yes. Plus, obviously, we have two main advantages. One is the dose is less. It's rather than using the systemic way, because we are directly giving the drug, as well as the onset of action is rapid. Right. Okay. So, what are this mother has some concerns, as you mentioned. She is in worry whether this child require long-term steroid or the long-term inhaler therapy. What do you think? Why this mother had some concern about this?
Because there is a myth usually among the society when we start them on inhalers, and they may need to be on inhalers for a longer period, and they become addicted for the inhalers. That myth is still there. That's why the mother is.
But usually when we start inhalers, we have to continue. It's a long-term durations, even though it's not directly thing. It's true. We have to use this long-term inhaler therapy. Why is that?
Because until they with times, if according to the phenotype of asthma, until they come out of the asthma, we may need to continue that to reduce the acute exacerbation episodes. So we may need to continue that, but we can have it in the low doses.
As you mentioned, yes. As you mentioned, the mother is having that's a myth, obviously, right? How do you overcome that? What are the important information you should give to the mother to get her on board with your management?
So I would be giving her the idea about the oral as well as the inhaler medications. The advantages of inhaler medications, as I said, we are giving the drugs directly to the site and low dose rather than the oral. And also every 3 months, by 3 months, if there is a proper compliance, most of the times we will be able to reduce in the doses, and with time we may be able to come out of the inhalers if the child is having a proper compliance. So if we say
if
that
you give such a deadline 3 months, if the conditions might not, obviously this is severe asthma. I will come to that later. So obviously we cannot stop or step down inhalers in 3 months' time. So then you are giving wrong information at the end of 3 months. Mother might not consider to continue with inhalers. So how do you overcome that? It's a little tricky to give such a duration or some deadlines, because after that deadline, if still we want to continue the inhalers, obviously parents might get little scared. Obviously, then they question back. The doctor said that this can be stopped after 3 months, but still you are asking to continue. So what are the other things you should tell the mother to get her on board about this management?
If she does not use proper medications, the drawbacks of not using the medication, can they be told, sir? Like,
okay, so what are the possible side effects of these inhalers, adverse effects? If I say educated mother, she is very worried about the side effects of steroids. She might ask, doctor, you are giving steroids for long-term durations, whether my child will get some adverse effects. So then how do you answer that question?
I would say, sir, usually most patients do not experience side effects, but they can but they have local effects only, such as dysphonia and candidiasis only. More high dose and long term ICS may lead to side effects like steroid osteoporosis and weight gain. I can tell that if child is on low dose, only local side effects are more than the systemic side effects.
Okay, as this is mainly focusing on medical students. So yeah, so there are important things you should inform the parents. First thing is, we are giving these long-term medications because the disease is a long-term disease. This is a chronic disease. Because of that, we are giving medicines, but obviously vice versa not happen. Because of medicines, disease will not get progress. You have to give it very, very clearly. This is a long-term disease, chronic disease, or the Vidandata Roga. Because of that, we have to give these medicines also longer durations. It is not the drug causing the disease. Drug we are using because of the disease. That's the first thing. Second thing about the side effects, yes, as you mentioned, we are using very, very low dose. Because of that, obviously can have side effects, but these are very, very minimum side effects. Majority are local thing. They might affect their growth, but that's also potentially very small amount. Even studies proven is about around 0.5 centimeter. But that is also the important thing is our purpose of giving these inhalers or the inhaler corticosteroids as preventers. So this is to prevent further episodes as well as the symptom control. So because of that, the most important thing is if she doesn't know, he or she, the patient doesn't use this drug, or the parents don't give it to the patients, and if the child develops recurrent attacks, then anyway child has to be on steroids, recurrent systemic steroids, though hypoxia and rest of the problems. So the side effects or adverse effects of these recurrent episodes or with uncontrolled asthma would be more delicious than the deteriorates than adverse effects of long-term low-dose steroids. That's the important thing. Okay, so we have to tell always the risk versus benefits. When we consider in the benefits, the risks are very, 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 very low, even used in the long-term use. Okay, so we have to give very clear idea about the, yeah, fine. Okay, so if a child presenting with the current episodes of wheezing, you think this child require long-term inhaled corticosteroid. What are the indications to start the long-term inhaled corticosteroid therapy in a child with asthma?
So if I suspect a high probability of clinical bronchial asthma, sir, I would be starting long-term prophylaxis. If they have typical symptoms.
High probability of bronchial asthma means? Then the diagnosis of bronchial asthma is almost certain.
Okay, sir. Yeah, when the diagnosis of bronchial asthma is almost certain, and if the child develops frequent symptoms like daily, monthly symptoms, and awakening night symptoms, and disturbances with the activities and disturbance of schooling, I would be considering a long-term inhaler therapy, sir.
Yeah, so it's important to identify the severity of these symptoms, frequency of the symptoms, and how these symptoms affect the child's day-to-day life. And the risk of exacerbations, especially the risk factors. We have to consider all these things, not a simple the frequency, once a month symptoms like that. But we have to get overall frequency also we have to consider, obviously. But if say, that's why I just want to do this. So if a severe attack, if it is a severe attack, so then if it's child require ICU care, or if especially child require intubation due to asthma, that's a lifetime risk. That means if that child, actually we have to give lifelong inhaler steroids because of this risk. If a child require ICU stay, so that means it's preceding 12 months, it's a risk factor. Like that, there are some risk factors of exacerbation. So we have to consider, as well as the frequency of symptoms, more frequent symptoms, once a month, or some significant symptoms once in 2 months, like, plus environment. All these things we have to consider. And earlier we consider some other social factors as well. For example, their stay. If they are living far away from a hospital, so that might be an indication to start prophylaxis. But other thing is use of short-acting bronchodilators. What is the action and what is the place of short-acting bronchodilators?
Short-acting
short-acting, yeah.
Yes, inhale a short-acting bronchodilator. We are using salbutamol, where we can give 100 mics, 2 to 6 puffs, and up in a acute exacerbation we can go up to 10 puffs. We can give, so it has a rapid action, and within 5 minutes that start to act, and there will be an improvement in the symptoms. So
the important word is, yes, we are using them as relievers and the inhaler corticosteroid as preventers. Okay, so preventers and relievers. So short-acting bronchodilators are relievers, just relieve symptoms when they develop symptoms. Okay, so that's an important thing. And there's a question about this use of Montelukast or the leukotriene receptor antagonist. And there's question regarding the use of Montelukast as a monotherapy, long-term management of asthma, not feasible or accessible. Whether inhaled corticosteroid therapy is not feasible or acceptable. But the thing is, the leukotriene receptor antagonist, that is, leukotriene is only one mediator in the complex pathway of inflammation. So this is very complex, we know. Very complex inflammatory process is going on. It's not mediated to single or few inflammatory mediators. So leukotriene is only one. So because of that, we cannot control all asthma with Montelukast. So as a reliever agent, it's a very, very weak reliever medications. So because of that, there is no place for Montelukast as a monotherapy or even a short-term therapy. So even you have become doctors, and still we see some wrong practices. Use of 1 or 2 weeks of Montelukast, there's no place, obviously. Its role is mainly as an add-on therapy only with inhaler corticosteroids, because the inhaler corticosteroids is the currently available best control measure, right? Fine. Okay. So you mentioned about the triggers. What is the place of triggers? And you mentioned this child. What is the most possible reason for this child's acute exacerbation?
This child, sir, he's a non-wheezer for last 9 months.
Yeah.
Frequent wheezing episodes, and the main trigger for this child in this episode was a dusty exposure, sir. Significant dusty exposure, where there is a repair of house started 1 week back. Since then only he has developed this cough for 3 days.
Did he have fever this time?
But fever, sir, after admission only, or admission at
how many days after admission?
No, sir. On the day of admission, he had fever. But cough was there for 4 days, which precipitated by dusty exposure.
Yeah. What is the commonest reason for develop acute exacerbations in asthma at any age?
Usually viral infections, sir.
Yeah, it's mainly viral infections, especially viral upper respiratory tract infections. Okay. So yes, usually we attribute this dusty environment, dust exposure, and various things. Environmental is obviously, these are very important. to have poor control in asthma, but usually if they present with this type of severe acute exacerbations, most of the time it's associated with an viral, more infective, usually viral upper respiratory tract infection. Because this child had fever means obviously infection was there. Okay, so rather than just the environment, it is because especially small children, as you mentioned, still we don't know what is the type of asthma in this child. It may be a little advanced thing, but just to mention, because there are various types of asthma phenotypes. I don't want to go into details of these. Different, especially these viral induced wheezes, dusty environment, whatever the dust is, it won't work. That means it is not a trigger, real trigger. With viral induced wheeze, it's induced by viruses, not the environment. Okay, so that's most of the time is older children with allergic asthma usually causing this problem. Okay, fine. As we are running out of time, so I just wanted to give some information, ask a few questions about the acute exacerbation, how to identify, how do we manage in acute stage briefly, and the long term, how do we decide about the long term treatment, and the steroid side effects, how to break this mix, and how to get the parents on board with our management plan. Right. Then once you discharge this child, so you have to assess the child frequently. How do you assess the asthma control in this child in your next follow-up visits?
There should be a regular follow-up for this child to be arranged at the clinic level, sir, to assess the compliance as well as the knowledge about the disease. I would be checking, so that I will review the child, I will assess the child, I will adjust the medications.
Okay.
I can ask, although we can ask for the asthma symptom chart, but we can assess with the main 4 clinical features that called as symptom assessment. We can ask for daytime asthma symptoms. If it is there for more than few minutes, a daytime symptom for within a month period, more than 2 weeks, or if there is a night waking episode like night cough and SOB, if that is even one episode is significant, and also any activity limitations, we can check whether the child can't play or can't study or can't laugh and cry. And also I will be asking whether the child needed the reliever medications more than once a week. So with these 4 symptoms, I can assess, and according to the score, we can decide whether the child is having well-controlled, partly controlled, or the poorly controlled asthma.
Yes, so asthma control is mainly assessed. So we are following the GINA guidelines. According to that, it's simplified. So as you mentioned, we are assessing, we are mainly focusing on these 4 criteria. With that, we assess whether this child is having control or the well controlled or partial control or uncontrolled symptoms. Okay. Say child is following up with your clinic, so the compliance or the adherence to treatment is good. And other thing is, say later, again child is coming with, again, not the severe episodes, but persistent symptoms, despite to have given the inhaler corticosteroid or the combined inhalers also, but still symptoms are not under control. What are the possible causes?
Even though there is a proper compliance, we are seeing we are seeing poor response. Am I right, sir? Yeah.
No, yeah. So no, this stage child you have prescribed the drugs, but still coming with persistent symptoms. How do you assess? What are the possibilities?
Yes, I would be assessing the compliance first of all, the compliance of the parents and the child, and the inhaler technique I will be assessing, and the frequency they are taking, and if there is a precipitating factor at house, including the triggers, if we can reduce that in non-pharmacological way, I would be considering it. And if the child is obese, I will be advising them for reducing the obesity part. Then if after those things also, I will be reviewing the child. Then also if the child is having persistent wheezing episodes, I will be considering alternative diagnosis of bronchial asthma, sir.
Okay, so what are the other clinical features you would consider about the possible other differential diagnosis, especially a child presenting with some, not this child, some respiratory symptoms with some wheezing episodes, but you have started treatment, still as the response is poor. There are some other conditions can mimic asthma. So what are the other special clinical features physical signs and history or symptoms would suggest you of alternative diagnosis or the red flag signs in asthma?
Yes, sir. First of all, I would be from the history, I can see usually bronchial asthma does not cause significant failure to thrive. If there is a significant failure to thrive, I would be thinking of other underlying conditions. And if although the small children can present to us with isolated cough, may be a symptom of bronchial asthma. But if there is only persistent isolated cough, I would be thinking of any airway obstructions. And in the history, if the child has early onset of cough and wheeze, then that is also suggestive of any congenital abnormalities. And if they are in examination wise, if I see a stridor, if I see clubbing and persistent lung signs, then I would be thinking of suppurative lung diseases like bronchiectasis and upper respiratory tract obstructions like tracheal or aortic arches, and which can cause obstructions. And if there is a family history of any chronic illnesses like cystic fibrosis, primary ciliary dyskinesia, I would be thinking of that. And I will be assessing the response for the medications. If there is persistent poor response to the medications, that is also suggestive of some other underlying problematic conditions.
Okay, yeah, yes. So important, right? Fine. Dr. Surantha, we are running out of time, no? Are you there? Yeah. You want to add anything? Dr. Surantha? Okay, yeah. Yeah, Dr. Abi, yes. You gave your answers were excellent. Right. So there was some chat book. There were some questions also. Just before winding up, I just want to go through these questions also. Right. Okay. Montelukast, yes, gone through the role of, yeah. What is the role of inhaled steroids during acute exacerbation of bronchial asthma? Yeah, it's like this. So, as one of you asked this question, the asthma is a condition with varied degree of severity. You know, there are steps in the GINA guidelines, step 1 to 5. Step 1 is the mild stage. They can have increasing symptoms. So that is also we can consider as an exacerbation. It's very mild exacerbation that according to current recommendations, rather than just giving the short-acting bronchodilators or salbutamol, better to add steroid containing inhale as well during that acute episode only. That means when the child is having mild exacerbation of symptoms. So that stage, yes, there's a place for inhaled steroids because asthma is anyway chronic, it's a inflammatory conditions. Increasing symptoms means definitely this inflammation has a little increase. So because of that, if you are giving only short-acting bronchodilator or salbutamol, there's a place of giving additional inhaled steroid as well. That is step 1, very mild increase in symptoms. But otherwise, always, if it's an exacerbation, we have to use systemic steroids. The inhaled corticosteroid won't work in an acute stage. For example, almost all the studies done in world with acute exacerbation of asthma, the definition of exacerbation or defined as increasing symptoms which require systemic steroids. So by definition, you have to give systemic steroids. That's a practically also those are research. So there's no place for actual significant increased symptoms. So with an exacerbation. Second line drug side effects, because there are various drugs are there, but usually we don't use these things. But mainly we are using the long-acting bronchodilators as add-on therapy plus Montelukast There are some issues with Montelukast also. Even there's a black box warning signs with some behavioral effects, and it's including involved in CNS, but usually they are safe. Role of nebulized steroids in acute exacerbation of bronchial asthma, that is also again a debatable thing. We are using this nebulized budesonide in children with acute exacerbation, but the problem is in acute exacerbation, the problem is the airway narrowing. Sometimes it won't reach, if you use an nebulized steroid, it won't reach the airways which narrowed, significantly narrowed, or which actually need steroids. So because of that, it's always advisable to use systemic steroids. Sometimes nebulized steroid might play a supportive role, but complete inhaled nebulized steroids might not work, but still there are some trials also. So still no guideline has given nebulized steroid as a first line thing in acute exacerbation of asthma. Yeah, the mimics of asthma, there are a lot of conditions, other conditions, maybe the genetic conditions like cystic fibrosis, primary ciliary dyskinesia, or the structural abnormalities of the airway. Sometimes the significant bronchomalacia might be there, or some vascular ring or cystic congenital cystic lesion or something compressing the airway, because it's not completely bronchial asthma, but sometimes they can present with symptoms like mimicking bronchial asthma. Wheezing symptoms might be there. You might hear some bronchi also, but wheezing sound. But sometimes it may be not polyphonic wheezing, it may be monophonic wheezing, especially if it is obstructing a major airway. Like that, there are some other conditions causing or can
Channa?
mimic. Yeah.
We are coming to we are surpassing. I think.
So you can make the concluding remarks. Yes.
Yeah, concluding. So I think in this even asthma case, what I want to say is now words like SOB, please don't use. Please tell shortness of breath. Don't use the shortened versions during the examination. The second thing I want to say is one of the common question we ask is why you say it is chronic asthma on examination. So anterior posterior diameter and the hyperresonance sounds during the percussion is very important. And then added sounds would be crepitations and bronchi. And then look for stigmata of chronic use of steroids, right? And then the postgraduate stage, we may ask even benign intracranial hypertension. And I can still remember when I was in UK, that child had is around 12 year old, followed up in the clinic, the shunt also to treat for benign intracranial hypertension. So these are extreme forms. And then the other thing is, please concentrate on the simple things. And then very well, one of the highlights of the history taking is it's very important to have set the goals, like simple goals. Every day attending the school, good sleep in the night, and being able to carry their hobbies, and then not to disrupt that childhood lifestyle. And then very important to know the mother's expectations and child's expectation, especially when the grown-ups, and know about the modern day therapy. And the simple thing like Montelukast is also very important. Sometimes we ask the side effects. They can have night terrors, etc. And then so the set goals are very important, how we achieved. And know about the smoking, passive smoking, the direct smoking, as well as third hand smoking. Even a person who smoke in the room, that the chemicals may lie for another 6 months. So there are a lot of new developments. I think I didn't try to stop Channa because a lot of people were still hanging on to their computers, and then was in the Zoom, but we had to end it. So we are very thankful to all the two other examiners. One is Channa Disa, he's a pediatric pulmonologist, and other my colleague is Professor Randola Ranavaka. So this is, I think, we did it experimentally, and discussion went beyond the given time, 20 minutes. But probably you saw the question, you were able to hear the question and answer sessions. We did not, actually the candidate, they did really well. We did not sensitize them regarding the possible questions. And then they went there and took the history. So you can see the fluency of the candidates, how very well they kept the momentum going, very clean histories, proper good English, and continue to the end. And then good examination, very focused manner, and they summarize it nicely. And the answers for the questions were very brief, didn't drag on for some time. So many questions. We are not going to answer so much question during a 20-minute period. But this gave you a good insight into you. Only difference would be, I think, candidate did their bit. They presented it during a short period with a summary, and only the discussion drags on a little bit, so for allow you to listen to more and more questions. So I think we will cut down on the discussions a little bit next time. But because once we give a mark, later we can add on. We can go for a discussion. So the next week we try to discuss 2 long cases belong to medicine. And I think to give a mark, my mark would be around 60. Would you agree, Channa? 60
Yes,
to 65?
of course. Yeah.
And you made her very tired asking
So many
questions for a
questions.
long period. Yeah, she should be given another 5 marks. But I think this would be very useful for all the medical students. Probably next time when you see when you come across a nephrotic syndrome or acute asthma case, examiners won't have a easy task of asking questions, because you may be knowing all the answers. Thank you very much for all the people. I think 300 odd people joined the Zoom meeting, and we'll meet next week. Thank you all.
Thank you.
Thank you, sir.